My name is Alufik. I'm junior health officer at Mulago National Referral Hospital, and I'm humbled to be your moderator today for this eco session. And today we are delighted to share with you yet another urgent and complex topic on approach to a convulsing patient. And we have a team of experts that will discuss with us in detail about on how to go about this. On patients that if you meet a convulsing patient, the truth is that they are quite not easy to manage, especially if you're not equipped with the right skill and knowledge on how to manage them. So we'll have both we shall look at both in patient care and also before the patient reaches in the hospital as we join this session. So I will introduce the team of experts that are joining me on this one, some of whom I have here in this room and others are virtual. And I'll give each of them a chance to introduce themselves. So I'll begin with Mr. David.
Yes, good afternoon, everyone. I'm called David Muyomomi. I'm an emergency medicine resident at Makerere University. I'm glad to be here today, and I'll be your case presenter. Thank you.
Thank you so much, David. Then Ms. Helen is here.
Good afternoon, everyone. My name is Helen Ozia. I'm a critical care nurse working at Kamempe National Referral Hospital as area manager. I'll be taking you through emergency care of the convulsing patient. Thank you.
Thank you so much, Ms. Antani.
Thank you very much. My name is Ntambi Umaru. I am an emergency medical technician, and I am glad to be part of the specialists tonight in the house.
Thank you so much. And the team online, we welcome Mr. Kadu Martin. Please introduce yourself.
Good afternoon to you. I hope I can be seen. I don't know. I'm Dr. Martin Kadu. I'm a consultant neurologist working with Mulago Hospital, and also a physician and a clinical head for Directorate of Medicine. I'm happy to be with you. Thank you.
Thank you so much, Mr. Dr. Kadu. And before we proceed and to start, we need to set some ground rules so that we have utmost of this discussion. So we kindly request you, our participants online, that you kindly keep your mics mute during this until you're given chance to talk. You will be requested to raise your hand in case you have a question, and you will be given chance to share. We hope we allow this session to be interactive and engaging. So kindly share your thoughts and comments online. Can't hear you. Kindly share your comments in the chat, and we'll answer all your questions. They will be noted and they will be answered. Then we have the CPD link to be shared towards the end of the session. So kindly do not share your numbers, the registration numbers in the chat, but rather fill that form that will be shared using the link that will be shared in the chat, and you will get it. So before we start our session, we're going to kindly request you to give us your expectations, our audience online, before we start our session. Please type in the chat and we'll be able to, they will be read. That's yeah. I see some people are already texting in the chat. Someone says, Francis Openga says causes of conversions are across all illnesses, but also encourage some to put up their hands and you be picked upon to give yes. This one expects to learn about the basic and initial things to do. Mr. Odula Joseph. Then Fiona Pio expects to learn how to transport a convulsing treatment. Interesting. Another one. Nawakula Sarah expects to learn managing over a convulsing soma patient. The emergency drugs on transfer of patients with convulsions. That's Cyril Brian. Thank you. Okay. Thank you so much for being engaging and being attentive. So without wasting any more time, let me invite Mr. David to take us through our case tonight. You're welcome, Dr. David.
Good afternoon, our dear listeners. Once again, I'm called David Movie, and I'm going to take you through the case. The case today is has been spiced up with some polls, and we shall be able to interact with you as we ask some questions, and you'll be able to answer some of the questions, and then we'll answer the question later. So we present to you a 28 years female mother, a para 3+0, 1 week post-emergency cesarean section, who was readmitted at Kawempe National Referral Hospital with a history of generalized clonic seizures and loss of consciousness. Upon arriving at Kawempe, this mother had a malaria test done, and it turned out to be positive. She was managed a case of severe malaria with IV attachments. Unfortunately, her seizures persisted, and then she was referred to Mulago National Referral Hospital for further evaluation, including a CT scan and for a neurologist review. When she arrived at the ED, primary survey was done using the ABCD approach. Initially, her airway was patent, but compromised by persistent convulsions and reduced levels of consciousness. Her GPS was 6 out of 15. And at this point, the team made it necessary that she should be intubated, and they went ahead to perform endotracheal intubation. Her respiratory rate was 30 breaths per minute. She was saturating at 88% on room air, and they provided assisted ventilation and then connected her to a mechanical ventilator. When they assessed the circulation, her blood pressure was 160 over 110. The heart rate was 110 beats per minute. The capillary refill was less than 3 seconds. And at this point, 2 large IV ball cannulas were secured, and the patient was given IV hypertonic saline cautiously, and then IV labetalol of 20 milligrams was given for the blood pressure control. When we assessed disability, still shows unresponsive post-victory, that is after the seizures, and the GCS remained 6 out of 15. Our pupils were equal and reactive, and continuous seizure activity was observed. When she was exposed, she had no rashes, she had no bleeding, and she had a surgical scar from the C-section, which was clean and was healing normally. So this takes us to our first poll, and from this primary survey, what are the three emergency conditions in this patient?
So, audience, you have a question there, and you're requested to answer in the chat. So, the volume is low. Yeah, we have some few minutes in the poll. Okay. So, Mr. Dr. David,
Let's switch. Let's switch. 70% better. Oh, thank you, our dear audience, and unfortunately, the poll comes to an end. Let's see what priorities we had in this case. What bedside priorities we had. So, next slide. So from our case, we had 3 major threats to this patient, and the first major threat was that she was having an obstructed airway because her levels of consciousness were decreasing, and what led us to knowing that her airway is getting obstructed is that she had lost her airway reflexes, and her GCS was 6 out of 15. This poses a risk to her in that she can easily aspirate and end up with aspiration pneumonia. The second threat was hypertensive emergency. When we look at the BPs, her blood pressure, initial blood pressure was 160 out of 110, coupled with a GCS of 6 out of 15. This puts her at a risk of a hypertensive encephalopathy and also stroke. And then the persistent convulsions, which were not responding to the initial therapy, can be classified as status epilepticus, and this poses a risk of neuronal injury and also a big risk of cerebral edema. So, based on the above information, what are your management options? That brings us to our second poll.
Thank you so much. Just like in the other poll, kindly answer the questions. Just to recall the question, based on the above information, what are your management options for this patient? The question again, based on the above information, what are your management options for this patient?
Okay, thank you, colleagues, for that participation. So what we did for these threats is that for the obstructed airway, in order to prevent aspiration pneumonia, we intubated the patient. For hypertensive emergency, in order to prevent the encephalopathy, we had to give IV labetalol 20 milligrams starts, and for the status epilepticus, we gave the patient IV midazolam. It is always very important to reassess and monitor the patient as the more we get more information. So what happened in the VD to stabilize this patient is that when she arrived, her blood pressures were noted to be 160 out of 110. A urinalysis which was done revealed proteinuria of +3. And the diagnosis of postpartum eclampsia was made at this point, and she was initiated on IV magnesium sulfate and given IV labetalol and subsequently mechanically ventilated and sedated. And this bought us some time to find out more information about the case and led us to doing another sample history. Her signs and symptoms included convulsions, loss of consciousness for 1 day prior to admission. She had no history of prior headache. She had no visual disturbances reported, had no known history of allergies. She had been on medications, which included analgesics and antibiotics for the post-cesarean section, post-CS. And these included terms like paracetamol, Metro, and Ampiclox. Past medical history, she had no prior history of epilepsy or hypertensive disorders. We couldn't ascertain her last meal history because of the altered level of consciousness. And events that led up to this kind of presentation is that she developed convulsions at home. She was taken to Kawempe and she was diagnosed as a severe malaria case, treated with IV attachment, but her seizures persisted and she did not improve despite this anti-malaria therapy. During the secondary survey, GCS remained 6 out of 15, and the seizure activity persisted, still having tonic-clonic seizures. The cardiac system, she was tachycardic, she had no murmurs. When we examined the extremities, there was no focal weakness identifiable because she was unconsciousness. Her pupils were equal and reactive. She had no neck stiffness. The chest was clear with scalpation. The abdomen was soft, non-tender, but the C-section scar could be seen clearly and was healing normally. The uterus was contracted. And this brings us to poll number 3. So based on the above information, what are your differential diagnoses in this patient?
Kindly, our audience, answer the question on what are your differential diagnoses in this patient based on the above information.
Patient was like has eclampsia, short sibaddeko nsanze kibuuzo.
Okay.
Welcome back, colleagues. So this is a list of the possible differentials we could have in a patient who presents with seizures. We have a mnemonic that is called vitamins, where you have vesicular causes which can include hypertensive crisis or CVA, infectious causes like cerebral malaria, meningitis, trauma or toxins, which include organophosphate poisoning, carbon monoxide poisoning, carbamates, and so forth. And also autoimmune causes like Hashimoto's encephalitis, neuropsychiatric lupus, erythematosus, metabolic causes like DKA and hypoglycemia are quite common as well. And also we have iatrogenic causes like magnesium sulfate toxicity, sedation overdose, and also neoplastic causes, which can include any tumor of the brain, like glioblastoma multiforme, meningiomas, pituitary adenomas, and so forth. Our investigations included a CBC, liver function tests, renal function tests, urinalysis, and microscopy. The CBC, the patient had an anemia and a thrombocytopenia. Liver function tests, her aspartate was elevated at 120. The alanine and the transferase was also elevated to 200. Creatinine was also elevated, and on urinalysis, the patient had proteinuria of plus. And microscopy, the DS was still positive with one plus in 5. And we went ahead to do also a brain CT. Next slide. So that brings us to poll number 4. What is the interpretation of this CT brain finding shown in this image?
Thank you, our audience. Kindly answer this question.
Okay. Having done all these investigations, this patient had a large right ventricular, intraventricular bleed, and some of the supportive measures that we undertook included protecting her airway, which we protected by intubating the patient. We mechanically ventilated her, maintain her circulation to greater than 94%. An NG tube was passed for feeding. The patient was catheterized to monitor urine output, and her blood pressures were measured every 15 to 30 minutes. Some of the specific measures that we undertook included management of threats, and like I said, some of the threats, one of the biggest threats would be increased intracoronary pressure, and this was managed with hypertonic saline, 3%, 5 mils per kg. A bolus which was given over 10 to 15 minutes. Then hyperthermia was managed with IV paracetamol, 1 gram hourly. The head of the bed was elevated to 30 degrees. This helped to facilitate venous drainage, and her neck was kept in a neutral position to avoid jugular vein compression. The other threat was also elevated blood pressures, and this, like I said, initially she was given a loading dose of 20 milligrams of IV labetalol over 2 minutes, and this was repeated every 15 minutes. She was given up to 40 milligrams to achieve blood pressure control. So, yeah, so seizure control, she was given magnesium sulfate, and the loading dose of magnesium sulfate, which was given to her, was 4 grams IV over 5 minutes, and given slowly to avoid toxicity. And then she was given an additional 10 grams IM in each buttocks. In each buttocks, she was given 5 grams. Then a maintenance dose of 5 grams was given every 4 hours until the last seizure was observed. But as we manage patients with these kind of seizures, we know that they end up getting refractory seizures, and so refractory seizures were managed with IV midazolam. This patient had an infusion of 0.2 milligrams per kg per hour, and this was treated to control the seizures. She was also given prophylactic antibiotics, was given ceftriaxone 2 grams, metronidazole 500 milligrams IV 8 hourly, this was prescribed for 5 days. For the intraventricular hemorrhage, the patient was scheduled for surgery. Prior to the surgery, the patient was transfused with 2 units of whole blood because she already had a thrombocytopenia. We couldn't get platelets, but we managed to get her whole blood. A craniotomy was done by the neuro team, and an external ventricular drain for CSF was done. Specific management disposition. This patient, after surgery and was back on vent, was supposed to be immediately transferred to ICU for continuous hemodynamic and neurological management, and was also supposed to be managed by a multidisciplinary team which included obstetricians, neurologists, critical care specialists, nephrologists, and hematologists. And also there was need to assess whether she needed organ support, maybe renal replacement therapy if it was needed. Follow-up, patient was supposed to be monitored her blood pressure is monitored every 15 to 30 minutes until she was stable. Her urine output was supposed to be monitored. Deep tendon reflexes were supposed to be monitored every at least 12 hours to assess for magnesium toxicity. Then serum creatinine, electrolytes, liver function tests, and platelets were to be repeated after the initial therapies. Unfortunately, the patient remained in the ED due to lack of ICU space, and the patient continued on mechanical ventilation and sedation, and the patient succumbed to the complications of intraventricular hemorrhage and prolonged status epilepticus after 7 days. So that brings us to the end of the case, but so we are going to go into the details of the pre-hospital management, and we're also going to look at the nursing bit of it, but these are going to be handled by my colleagues. And some of the questions which you'd want to ask yourself would be, what do you need to prepare for pre-hospital care for this kind of patient? Which staff, which patient, which equipment, which mode of transport, documentations, and how would you utilize the SBAC protocol, SBAC model to handle the patients? Where you identify, you report about the situation, you talk about the background, and you document your assessments and the recommendations that you want the team on ground to handle. So for the nursing, you would want to ask yourself, is there anything else that you want to know about the nursing? But those are questions which are going to be answered by the teams, the experts who are already here. And without wasting time, let's now dive into the ED and specialist management for convulsing patients. And this brings us to the question of how should we manage this kind of patient? Thank you, colleagues. That's it for me.
Thank you so much, Dr. David. You can share your flowers in the chat, and we'll be able to see them for him. Thank you so much for the detailed case presentation. And we will allow our audience to ask questions. So if you have any questions, you can raise your hand. Yeah, there is someone here. So, Prina, start the question.
Yeah, thank you so much for the presentation. I would love that the next session of the presenter, let him get nearer to the microphone, yeah, so that we really get enough audibility, because it's as if you are speaking to yourself. The voice couldn't come out very clearly. Otherwise, I'm really grateful. The presentation was clear and we could read from what was presented, but the voice couldn't come out clearly. Thank you so much.
Okay, Krina, thank you for that comment. Then we have Mulungi Jonathan. Kindly unmute and give your question.
Yes, thank you so much. Good afternoon to everyone. I'm Dr. Jonathan. Mine would be to the presenter. When we use, for example, for seizure control for some of the patients who keep on having the seizures, at what level do we use drugs like levetiracetam, commonly known as Keppra, and what can be the maximum dose we can use if someone continues to actually have these continuous seizures, even after giving, let's say, mag sulfate or phenytoin? Back to you, the presenter. Thank you.
Thank you so much for those questions. The other people have questions, please let them keep coming in the chat. We have a co-moderator who is managing all those chats questions and they will be attended to. So, Dr. David, kindly.
Yes, I would like to take on that question asked by one of our colleagues who asked about KEPRA and when we use KEPRA.
Yeah, when do you actually transfer? When do you choose to go to use KEPRA, and what's the maximum dose you can use?
So KEPRA, actually KEPRA in the current treatments, it is one of the first line drugs that is supposed to be used for seizure controls. We have all along used benzodiazepines like diazepam, lorazepam, and even does for as our first line. But recent studies are suggesting that we can use KEPRA as first line, and the maximum dose you can go for KEPRA is 3,000 milligrams if the patient is not responding to benzodiazepines.
Thank you, Dr. David, for that presentation and for answering his question. And so we proceed to the next presenter. And I want to welcome Mr. Ntambi, who will take us through the pre-hospital and inter-facility care during transportation of a convulsing patient. You're welcome.
Thank you very much, our moderator, and I am glad, David, that was actually quite intense. And from the looks of things, I would tell definitely we needed to have the transfer of our patient from one facility to another. And I am glad that we could probably share something that should be taken note of or considered ahead of our plan too. So it is important for us all to appreciate that going forward, there must be plans or we need to move the patient. And in this case, I would want to zero down specifically on the transportation needs for patient care. Care for transport will always differ, the number of things that will interest ourselves. And specifically, we want to concentrate more on what are the triggers? What is it that is driving us to really request for the transport? What have we really observed? And these are some of the key things that you should take note of. We'll talk about the staffing, the condition of your patient, what are the equipments you have on board. Very importantly, the mode of transporting. In this case, you realize that our patient needed a specific positioning where we need to raise to 30. So if your ambulance is not in position to do this, then there are possibilities that we might not have a lot. Review of documentation is important. We are seeing that the patient is picked from Kawempe, we're heading to Mulago, but ahead of it, what we have to really convince the receiving facility that it is important for us to have this patient be received, and that's where we come in. So we are saying that in your plan, you must really know that the determinants or what is going to drive you to request for this, one is the individual's condition. And specifically for our patient, you realize this is a critical patient. The other factor that we shouldn't take for granted is the location. Where are you located? Because this will determine the distance we need to cover and the likes. And then the patient's condition will guide you on the specific requirements when it comes to what do I need on board that should not be left out and becomes very important. So ensuring the safe and effective transportation of our patients, we are saying that one, we need the ambulance services. That is for the emergency situations. Patients require a number of things. And here we are looking at, is your ambulance suitable? That's in terms of taking on the medical part of it. Don't think that if I convert my small car, I should have it be turned into. The vehicle should be suitable for the medical transportation. We are talking about the equipment for the patient care. And straight away, without looking aside, our patient needed Class C ambulance because somehow we are hearing a discussion where they need a vent. We are seeing that the patient is deteriorating somehow we need to take care of the medication that has been given. So equipment is very important. However, we also have what we call the non-medical transportation, specifically the non-emergency, that is medical transport for patients who need the medical care, but not to that specific grounds where you need to ensure that I must have this. And key things to take note of is, does your ambulance facilitate a wheelchair? Want to access this patient is not critical, but he has an appointment. Can your ambulance have the accessibilities for the wheelchair? Because the patient should be able to benefit. We are talking about the stretcher in this particular case. What is the design of your stretcher? Will the patient be able to benefit from lying down if we decided to move this particular patient? So ahead of your planning, we are saying that the patient condition would be determined, would give you lines in which you should actually think about that, okay, this particular one, I need to understand the condition of my patient. Case presented, this was a critical patient who needed the Class C ambulance. No looking aside, we needed specialized team on board. The distance, it is important for us, one, the patient to quickly go in the facility where he's going to benefit from. But think of a scenario where you need to move close to almost maybe 200 kilometers to your next facility. Who is it that you have on board? So distance becomes very important. And then last but not, the specialized care. Critical patients need to be attended to by specialized individuals. And in this case, we are talking about advanced emergency medical technician. And specifically for our patient, he needed someone who is advanced, such that will be able to match the needs of our patient, specifically continue care, ensure that the patient is actually benefiting, and at the end of the day will be to destination. What are the benefits of ensuring that you observe the above? One key clearly benefit is this timely access to care. If you really have everything with you and probably you have the right team, the right equipment, there is that 100% that the patient is going to benefit from your primary planning. And that is why we are saying that the timely access is so important. Two, the reduced stress. Proper transportation can reduce stress and anxiety for the patient. And of course, we will be in position to tell that, okay, this is better, and we would love that. But also we are saying that if it is well planned, we have what we call the volunteer driver program. There are so many good people who would love to support transportation. And in this case, if we really have well and proper planned transportation, we'll have programs like the volunteer driver programs taken care of. Communities will have people that they can actually rely on. And in the long run, we'll realize that the patient needs are met. Important of planning. Why do we say you should plan? This tendency of people wanting anyone to come from where you are, then come jump on board, tell someone. We are going to miss out like the advanced planning, where we know that transport is well arranged, it is the right transport, it is with the right equipment, with the right people, and at the end of the day, we'll have the timeliness achieved, and of course, we have better outcome. The communication bit of it, when you plan ahead of it, the receiving facility is expecting, they will prepare for you, they will have even the teams be monitored while in transit, and in the end, we'll have all the needs and the requirements put in place ahead of you, and that makes it be very, very important for us to plan. Why still plan? You're able to meet what we would call the contingent planning. Just in case of backup means, I will be honest, I have encountered one of these incidents. I have a critical patient from Arua heading to Kampala, and in the middle of my trip, I encounter this incident where my ambulance break down. What do you do? What's your second plan? So planning will help us to mitigate some of the key things around here, and you'll always have the backup plan, which makes it be very important. And we are saying that by considering all these factors and options, patients can receive best transportation. They need to access the medical care and improve the overall well-being. So specifically, if you look at our case presented, I will be honest to you that one, you agree with me that our patient needed an ambulance class C, talk of class C, because key things that should have been on ambulance was the vent. The patient needed to benefit. We are seeing that the SARS for this patient an issue. Oxygen should be there. We need a monitor. And then the medications to be observed. We are seeing that the IV fluids themselves are actually a requirement, and hence the need for ambulance to have all these people. Trained personnel, if you look at the condition of the patient, we are saying it is important for us, specifically this patient, to benefit from an advanced paramedic. Why? Because he is in position to interpret and even deliver as instructed. So it becomes important that ahead of us, expertise in patient care during transport is very, very important. Train. Still more, you realize that this patient, there was a lot of need to communicate. Does your ambulance have the communication guides? We are saying that, okay, you don't have this, but do we have those closed loop tools to help us bridge all this? So communication needs, we are saying, one, we'll stay in touch. Specifically, maybe the receiving facility that is at the OPD. But then we're also saying that the person who is handling the case should be in close communication to update the condition of the patient. And it is important for us to keep records, because at the end of the day, I am taking note and I am updating the receiving facility that we set off when our oxygen, the SARS for the patients were 84. Right now, we are seeing that we are in actually 88. We are doing better, but it is important for us to have these communication gadgets with us. The documentation, top priority. I have seen a number of patients that have been moved, and you realize that at the end of the day, they ask, oh, okay, what did you do? Where is this? Can we drop all this? Let's make sure that before departure, we have the full filled form detailing this patient as the person on ambulance receive. When you receive, try to transfer the key requirements in your ambulance documentation. Make sure you have your new documents in relation to what you have received. Be in position to hand over what you have been able to do, not forgetting that you needed to observe what we call the history. And that brings us to the need to use SBA. This is one of the best. I, Tabi Umaru, an EMT. I have a 28-year female who was having a hemorrhagic shock, which already communicates to you that this is a critical patient, already on medication, which is very clear. So you identify who the patient is. Don't forget to tell us who you are. And at the end of the day, we should be knowing what we are dealing with. So importantly, let them capture what are the primary things that we need to pay attention to. One of the history will confirm that he had this Caesar started way back from home. We are seeing that he's even taken to the first facility, but then it has not benefited. We further see the patient being referred to Mulago. So it is from your background that all this information should be shared and probably passed on to the next team. What were the assessment? Please do not create your own assessment. It is important for you to first collect what is there. We are seeing that the patient's blood pressure was already 160, meaning that between me and you, we know that there's medication which is already on board. A number of them, for whatever has been recorded in terms of assessment, please collect it, have it be shared, and then it will guide on what we need to actually specifically continue managing the patient in transit. Assessment, assessment, assessment. And we are saying that do not forget to also give your recommendations. One, when you're receiving the patient, they are going to tell you this is a patient that needs the event, but remember the patient should be monitored. We need to continue monitoring the vitals. Remember, medication has been prepared for you. You have been guided on how you should really continue administering. Position of your patient is key because you've already been cautioned. We need to make sure that we should have this be taken care of. So if we alter with any of the above recommendations, then it will be worse. And at the time of handing over between me and you, we need to work closely, tell them that ahead of all this, this is what we have also been able to observe. And it becomes very important for you and me to appreciate. This brings us to the end of this, and we are saying that by you considering these factors an option, patients can receive the transportation they need to access medical care and improve their overall well-being. Thank you very much, moderator. That is how we could really take that.
Thank you so much, Mr. Nandi, for that detailed discussion. And the audience, please raise up your hands if you have some questions to ask, or you can type in the chat. If you have any questions for Mr. Nandi. Okay, we actually have a question from Jumba Moses. Jumba Moses, you can unmute and ask your question.
Thank you so much, Jumba Moses here. Thank you, team, and thank you, Tambi. I love your passion for EMT and transfer. Kindly speak to, in an ideal setting, I know it's what we describe, but kindly speak to equipment exchange. A case in context. We have this mother who probably they would have arranged to transfer to an ICU setting, but on a vent and possibly on monitors. How do we arrange that equipment exchange to come to the ambulance, preferably the class C that you have spoken to? And then lastly, how do you speak to most of the transfers we do, probably people do private vehicles. How do we help such a person reach the hospital, probably to have an ideal transfer to the next care point? Thank you so much. I hope I was audible enough.
Thank you, Mr. Jumba. One more question and Sylvia Nankunda. Nakunda can unmute and ask your question.
Thank you so much, core team. Great thanks to Mr. Umaro for that great presentation about pre-hospital care. As we clinicians, we still have a gap in clinical discussion. My previous person asking, how do we have a good transfer? We need to improve a lot on clinical discussions. I'm saying before you see this facility, as a clinical officer, whether the doctor or the person need to take responsibility and inform the facility where you are receiving. We are giving patients to ambulance teams, and we are not notifying the other areas where they are going. So, and ambulance teams may not discuss everything regarding the patients, because as clinicians, we be the one to admit the patients, and we know that time we are referring the case. So, as we are improving on our services, we need to take initiative as clinical people the time you reach a decision of transferring this patient, referring this patient, look for the next doctor or the nurse, definitely the doctor, because you're not handing over to the nurse. Look for your colleague, a doctor, and discuss. But we get issues as pre-hospital care where doctors in the next facility, they don't want to call their colleagues in the referring facility. Then I ask myself, why? Then why are you referring? You are sending the patient to whom one? So it's an area of emphasis, and I'm sure Umar would talk about it more, because as pre-hospital care providers, we are not the gods, we need support. Otherwise, I thank you so much.
Okay, thank you, Natunda. And for the next discussions, please restrict your discussion to the question. Thank you so much. So, Mr. Ntambi.
Thank you very much, moderator. And I must admit that when you look at the current situation versus specifically our question at hand, true, we still have issues to do with equipment and probably how we should be going about it. But in an ideal situation, we are saying that as the team in the transportation, please insist, where am I taking this patient? So this brings us to the point of communication. Please communicate. Confirm they have accepted to receive you. I am bringing an ICU patient. Has the ICU team accepted to take on this patient? If we have this taken care of, I think the issue of equipment, we will have dealt with it direct. Our biggest challenge is around the communication, that we ambush, let me use the word ambush, we ambush the receiving facilities, and at the end of the day, we demand that we want to take back our equipment and the likes. But I think going forward, it is important that ahead of our movement, let's be sure, one, the teams on board confirm that who is receiving us have what exactly is expected for the betterment of our patient. So you give them the details of the patient, they prepare for you, and then we can proceed. Issues to do with ICU, don't ambush them. You will still have the delays, and this will still cause the issue to say, I must go back with my stretcher bed. I should not forget to carry this. But all of this can best be addressed reaching the communication with that primary confirmation that we are ready for you. To the extent of how they are ready, it can only be confirmed when you have this closed loop communication. Thank you very much for that wonderful question. Then about the issue to do with the pre-hospital, I think like we said with the key requirements, the staff, the equipment, this is a game where we need to all remember that it is not showcasing. We are trying to give the best. And from my end, it will be disappointing when I have the best preparations and I don't work with the handover team, the team which is receiving me. That would really be mean of me. So I am still insisting and calling upon teams that we work as a team. We will bridge these challenges. And I assure you, for the little times we've been on the road and we've communicated, people have seen how beautiful it is to have this patient. Thank you very much.
Thank you, Mr. Ntambi, for the detailed discussion. I think next time we shall talk about the jam. How these days ambulances are not given away like they used to be. So maybe to answer a few questions, there are people asking about the sharing of slides. These videos will be uploaded to our website and also to our YouTube channel. Links will be shared in the chat. So those who are asking when, I think I've answered you. So allow me welcome Miss Helen Nzia, who will discuss the emergency nursing approach to a convulsing patient. You're welcome.
Thank you, moderator. Good evening once again. I'm Helen Uzia. I'm a critical care nurse working at Kawempe National Referral Hospital. We are going to look at the nursing aspect of the patient who is convulsing. And specifically, this patient came from Kawempe. So that is briefly introduction of a convulsing patient. These patients normally have abnormal electrical activity in the brain that results in violent involuntary muscles, and most times it's generalized tonic-clonic seizures, which was one of the symptoms the patient presented with. And the nursing care plan emphasizes the importance of rapid assessment, seizure management, blood pressure control, and monitoring of complications. The goal of all this is to stabilize the condition of the patient, prevent further seizures, and manage complications associated with seizures. When we do nursing assessment in emergency, the routine is to have biodata, chief complaint, all of those ones you see. But for this specific patient, as emergency, we are going to use the ABCD approach, where we are going to look at the airway, breathing, saturation, disability, and exposure. So I have a nursing care plan that I have made. We shall follow that. Next slide. So this patient was referred, and she had lost already her airway due to the persistent convulsions. We had also seen that she had low GCS. So what is the nursing diagnosis here? It is impaired airway clearance related to persistent convulsions and reduced GCS evidenced by, that is a typing error. We didn't have any secretions. So what is the goal of care? Is to have effective airway clearance. One thing is, as a nurse, you must recognize this is an emergency. You call for help. Then to protect the airway, you head tilt and chin maneuver so that you're able to improve on the airway, which is already compromised. You position this patient and ensure the patient is very safe. What is the rationale of all this? We want to prevent aspiration and promote safety because this patient is convulsing. At the end of it all, the airway has to be protected, and this is a multidisciplinary approach. We have seen that this patient from emergency unit was intubated. Then another goal for a convulsing patient is to have patent airway. One of our roles is to use oropharyngeal airway. Please, nurses, let's learn to use oropharyngeal airway for unconscious patients. Then if you can, if your facility has nasopharyngeal airway, you can still also use it. Nasopharyngeal airway is used for those patients who are unconscious so that you can prevent stimulating the gag reflex. And as a nurse, if the airway is compromised, you should be able to initiate an oxygen. For this person whose GCS is already 6, you have to upgrade to non-rebreather instead of nasopros. Yes. And you're able to attach monitors and check SpO2, and this is still a collaborative approach. You have already called for help. That means other team have come on board. So the rationale of putting nasopharyngeal airway is to prevent the tongue from obstructing the airway further, to ensure that there is adequate oxygenation to this patient. So when you evaluate, this patient by now had the nasopharyngeal airway, the oropharyngeal airway, and the patient was also intubated. The position was safe. This was all to improve the care, and in case of any secretions that may come, it will be improved by all these nursing interventions. Next, we shall go to B part of the assessment, which is breathing, whereby you look and listen and feel. This person was already in respiratory distress. She had a respiratory rate of 30 breaths per minute. SpO2 was 88%. The nursing diagnosis here is altered breathing pattern related to obstruction as evidenced by respiratory rate over 20. Specifically, she had a 30. She had difficulties in breathing. The goal of care is to prevent hypoxia. As a nurse, you're supposed to do respiratory assessment, whereby you do the respiratory rate, you check SpO2 at this level. In advanced setting of a national referral, we should be able to attach monitors to monitor this patient. But at a lower facility, you should be able to manually count the respiratory rate of this patient. And when you insert the the oropharyngeal airway. At this level, you should also prepare and put oxygen, rather NG tube for this patient, and assess for toxicity and prepare for advanced airway management. We have seen this has taken place in the emergency unit, and in advanced setting, as a nurse, if they have removed blood gases, you're supposed to evaluate. The rationale of assessing breathing is to improve oxygenation and treat the underlying cause. On evaluation of this patient in emergency room, the patient was already intubated and the respiratory rate was not normalizing, and the SpO2, the target was to have from 88% to 94%. Then the next assessment is the saturation. Under saturation, we look at softness of breath, capillary refill time, skin color change, and this patient had hyperthermia. The BPs were high. Capillary refill was less than 3 seconds. The nursing diagnosis is altered tissue perfusion related to vasospasm and increased blood pressure, evidenced by the high BPs which we have taken. And the goal of care is to gradually reduce these BPs. When you give aggressive antihypertensives, you can easily cause hypotension, so it's good to have caution. So as a nursing intervention under saturation, you are going to put up a line, and this line you're going to withdraw blood for laps. And you're supposed to restrict fluid management for this patient who had already high BP and administer the emergency antihypertensive. As we have seen, she received the magnesium sulfate and labetalol. As ongoing care, this patient already had NG tube, so antihypertensive will be given, the oral one, because he had a postpartum eclampsia. The rationale is to control the BPs. So after evaluation, at least the diastolic pressures will have been controlled to at least 140 millimeters of mercury, and the systolic at least below 90. And antihypertensives which are given has to be documented as a nursing care. The next is disability. Under disability, we've seen that this person had altered mental state. The GCS was already 6/15. She had persistent convulsions despite of giving magnesium sulfate. And we have seen that when she came in Kawempe, she had malaria parasites, but she received artesunate which was given, and she continued with persistent convulsions. That was the reason why she was transferred to Mulago. So the nursing diagnosis is altered mental state related to hypoxia, evidenced by GCS 6/12. The goal of care is to maintain cerebral perfusion and monitor intracranial pressure. The nursing care is assessing the GCS using AVPU, but at some level, this person was sedated, so we'll use RAS. And it is the nursing role also to check for brain stem cells. You check the pupils for reactivity. You do RBS, monitoring for convulsion and frequency, and you give anticonvulsants. This person has to be protected for further injury. You put up the rails, then prescribe medications like mannitol and hypertonic saline. Midazolam were all administered, and this has to be documented. So the rationale is to have a support on neurological recovery. So after evaluation, ensure that the patient is assessed regularly. For patients who are sedated, we use the RAS. You check the RBS. We have seen in the differential of this patient, hypoglycemia was also one of the things. So we've noted that after the patient is sedated, the convulsions have reduced, and document the care which is given. Then lastly is the exposure. Here we looked at persistent seizures despite anticonvulsants given. The nursing diagnosis is risk for injury related to seizures. The goal of care is to manage seizures effectively. Dr. Umaru talked about ISBA. It's also one of the way of communicating. If you're in a lower facility, you use that approach to communicate with the next facility. We've already seen the pre-hospital referral interfacility. So this person and the exposure, avoid restraining if the person is convulsing, remove excess clothes and nearby objects so that the person doesn't injure herself. You log around her for safety. Because you have now a multidisciplinary team, you are not going to work on this alone. You give the prescribed medications. The rationale is to protect injury and the surrounding of the patient. So after evaluation, We noted the seizures are reduced in frequency and the person is sedated. So we have an acronym for persons who are managed in ICU. Next slide, which is called Fast Hugs, BID. So this Fast Hugs, BID, as a nurse, it will guide you to holistically manage the patient. F stands for feeding. So you look at the needs of this patient. Is she supposed to be fed through NG tube or enteral feed or parenteral? That's one of your assessment you do as a routine. Ensure that person has pain control. Remember, she had surgery, craniotomy. Sedation, is it sedated lightly or you have trials that you plan to do? Then also this person is confined in one place. You will evaluate thromboprophylaxis if they are prescribed. If they are not, you can remind the doctor. Then the head of the bed is elevated for this person to prevent ventilator-acquired pneumonia. Also, prophylaxis has to be given. You can also start spontaneous breathing trials for a patient who is in ICU. Then bowel regimen to prevent constipation. Infection prevention, here you look at the lines. Maybe this person has a central line, cannula, catheter. If this is a long stay, you are going to evaluate and also do culture for this patient. Then the escalating of drugs in review of antibiotics, sedations, what are your daily plans? Then under vitals, if the patient is ventilated, your focus is on the mode, setting, oxygenation, weaning. Since you stay with the patient, you'll be able to give information whether the modes needs to be adjusted. You don't work in isolation, but you work as a team. Eye stance or inotropes and vasopressors. This patient had no issues concerning that. Temperature, she had fever, which was managed by paracetamol. Then antibiotics, she was given already. Then lines, we had talked of preventing infection on central line, catheters, ETT. Those are all things that you look at holistically. Then you check the skin, urological assessment, and integrity to prevent pressure sores on this patient. Thank you for listening. That is the end of my presentation.
Thank you so much, Ms. Helen, Sister Helen, sorry. And our audience, you can ask your questions. So you can raise your hands and you'll be picked. Ask your questions. Any questions for Sister Helen? Okay, if we do not have any questions coming in, allow me to proceed to the next expert, who is Dr. Kadu Martin, a consultant neurologist at Mulago National Referral Hospital. You're welcome, Dr. Kadu.
Thank you very much. I hope I can be heard. Just a minute. All right, I'm trying to share. So, okay. So, good evening, colleagues and friends and members. We've had a long talk about seizure management and the case presentation, which was all presented. And within a couple of minutes or close to half an hour, I want to just talk about briefly the seizure management, but it will be just a general overview about management and any other things, definition. And I have nothing to disclose or conflict of interest as I give my talk. And within this talk, I'll talk about the introduction, definition, epidemiology, and end up with the key messages. So, seizures, we know that they are one of the commonest causes of transit losses in consciousness, and which make patients present to the emergency medical care or emergency care for any sick of treatment. And we know that they are one of the commonest causes for short admissions among the neurological causes. Either somebody has fainted, either there is an accident, or there is a fever, and then somebody loses consciousness, and that's why we seek medical care and treatment. So while not all seizures are associated with the loss of consciousness, however, those requiring medical care usually tell us that there is impaired awareness and unresponsiveness. So people usually get seizures and they wake up, but then we get concerned when they don't wake up or they remain in the state of unimpaired awareness. And this prompts us to seek medical care. By definition, we'll define what we seem to have been treating recurrent seizures like status epilepticus, and which is defined as continuous or repetitive seizure activity, which is persisting for more than 30 minutes without having a recovery period between the attacks. So this definition takes in two things. One, that somebody is having recurring seizures. And then secondly, there's no recovery between the attacks. Then very few seizures usually last longer than a few minutes, because they could be brief seizures, 2 minutes, 1 minute. So, but if a seizure lasts for more than 5 minutes, then we have to treat like status epilepticus. We don't have to wait for the 30 minutes. You can't be with a watch and you're waiting to say that, oh, I'm waiting for these seizures to get away. Then I'll start treatment. So as long as it's 5 minutes and more, I'll start immediately to treat as status epilepticus. It's unfortunate that the case that we've seen today, that the patient had had seizures prior, 1 day prior to that admission, which I don't know, they ignored, or they could have sought medical treatment elsewhere, and the seizures were not controlled. Okay. Yeah, so all right. So before we go into that seizure management, we need to know what kind of seizures are we dealing with. And according to the new classification, the International League Against Epilepsy 2017, we came up with a classification which is now the classification that is recognized. So you note that all seizures are classified into 3 major groups. You have either focal, you have generalized. Focal means it affects only one part of the body. It could be the hand, it could be the leg, it could be one part of the body, one side of the body. Then generalized means, as long as they generalize, means there is loss of consciousness. So our patient had a generalized seizure because his level of consciousness was out. Then we have unknown. Some patients can come in and we don't know the seizure. We can't classify it. And we further go down to classify into the types. Is it focal? Is it generalized? Sometimes we can start with a focus, then you go to a generalized seizure. So we can say focal seizure with a generalized secondary generalization. That's why you see combined generalized and focal. Then unknown. Some seizures, we still can't classify them. So depending on what we classify, we come up with different types of seizures, and then there are the epilepsy syndromes, which we normally see in the children who are below between 5 years or even 2 years to around 13 years to 18. So all these are caused by different etiologies. It could be genetic, it could be structural, trauma, stroke, it could be metabolic, immune like autoimmune epilepsy and encephalitis infection and any other unknown, which we tend to see in these patients. So when we see these patients, what do we see? We can either see somebody actively convulsing or somebody just be unconscious but not convulsing. So that's why you're saying convulsive or non-convulsive. And convulsive seizures involve visible jerking, visible shaking of the extremities. It could be the extremities, it could be the eyes rolling up, it could be loss of consciousness with abnormal cries, secretions. Then we have the non-convulsive, which we normally see in ICU, intensive care, but they tend to involve the brain, but without showing any visible jerking. And we can still further classify into focal or generalized, depending on how we see on the clinical features of these patients. So you'll find that, for example, in ICU, that most of these patients will tend to have non-convulsive seizures. And without an EEG, a brain electroencephalography, we cannot identify. So you just see that somebody is not waking up or is deteriorating, but he's not actively seizing. So this is just a point that we should keep in the back of our minds. Now, the acute symptomatic seizures. Acute means that these seizures are occurring within a small duration or short span, maybe 1 or 2 days, compared to you've heard of terms like unprovoked or epilepsy. Epilepsy means you've had seizures for quite a long time and they're recurring. Whereas acute means maybe within less than 1 week, they have just been active. So which means there is something affecting the central nervous system, which rhymes with the symptoms of the seizures within that part. And among the causes, we can note that cerebrovascular accidents, which include strokes, which includes bleeding, trauma, subarachnoid hemorrhages, are comprising most of the percentage. Then you have head trauma. Then you have infections of any viral, could be bacterial. Then we have withdrawal syndromes, which are coming from either alcoholic withdrawal, which is a common problem now, then metabolic, and then the toxic, then we have others. So this was borrowed from the epileptic disorders. I request somebody to mute. I'm getting echoes. Sorry. Thank you. So we could have all these as part of the causes causing symptomatic seizures. Now, who gets these like status epilepticus? So the most common risk for status epilepticus is having a history of epilepsy. And it has been noted that around a third of these patients, 22 to 26%, who go into status epilepticus have a history of epilepsy. So we know the risk is around 3% in a year. That's if you have to take 100 people, we know that at least 3 of them, if you are taking people with a history of epilepsy, 3 out of 100 will get these bad seizures every year. And then in those with no prior history of epilepsy, we know that stroke is the commonest cause. I happen to be on the neurology ward in Mulago and or even in emergency. And sometimes for a stroke to present, somebody just collapses and starts having convulsions or starts shaking, only to do a brain CT scan and you find either he has a hemorrhage or he has, and in fact, and we know that around 20% of these patients who have had recurrent seizures or like status epilepticus, it's attributed to stroke. Then within the hospital, seizures are usually related to alcohol or benzodiazepine withdrawal. We've seen many patients who present with an alcoholic coma, and then because he has been admitted on the ward for a long time without getting the body accustomed to further alcohol, maybe 1 week, 2 weeks, and then he tends to get those seizures. Others are coming with binge drinking, then he's off, then 2 or 3 days on the ward without alcohol, then he gets withdrawal tremors, very common. And then you have medication toxicity, known to mention other recreation drugs that we are seeing now, cocaine, we are seeing drugs, pethidine, we are seeing benzodiazepines, and many psychiatric drugs can also be used either with an intent for suicidal ideation or just as a recreation drug. So why is this topic so important? We know that convulsive seizures can result into hypothermia because the muscles within the body are contracting against their free will. So you tend to have to produce a lot of heat, and then this raises the body temperature, causing hypothermia, which might be very hard to treat even in ICU. Acidosis, with the muscle spasms and contractions, we block off this transient blood flow into different organs and the brain too, and we increase the decreased oxygen levels and increasing the carbon dioxide levels, and then we definitely there's going to be more lactic acid production. There is rhabdomyolysis, breakdown of muscle tissue, aspiration because we are not aware of our trachea and esophageal openings during that time. The coordination is cut off, and then finally we can injure ourselves. People get fractures, especially the shoulder dislocations and shoulder fractures, and also in the femur, the neck of the femur, which are common and have been noted. So the longer the seizure, the greater the risk of cerebral damage. I think I highlighted this in blue because if I get more seizures and I take long to control them, it's like I'm burning brain cells. And that's why we see that people living with either epilepsy or any person having a seizure and gets a long seizure, we tend to have more prolonged temporarily cognitive impairments, or even longer than somebody who has a brief seizure. And if these are repetitive, then more pronounced cognitive impairment is bound to happen. Reason being, there is a cytotoxicity. As the seizure happens, we know of the molecular structures which take place. You're releasing neurotransmitters, some are excitatory, glutamate, and glutamate is going to make the seizure become more prolonged. We are going to affect the cells down in the brain, such that we interfere with the cell's way of normal conduction. The ions become disrupted, metabolism down in the cell becomes disrupted. the cells end up dying, apoptosis, because of increased accumulation of iron within the cell. Iron should not be within the cell, should be outside. As long as it enters, then we know that it's going to cause a cell death. Then you have synaptic reorganization. So synaptic means we recruit more cells, neurons, so that we can get more seizures. So usually these prolonged seizures can be seen on a diffuse weighted MRI. It's a brand of imaging where you can see actively where the brain is having these seizures when you're doing an MRI. Okay? If I'm too slow, you let me know auto fast. So when you are versed with a patient with seizures, what do you do? And our aim is to find the cause. And the best strategy is to get the best history that you can, which history comes from the next of kin, because the person that you are treating or that you are versed with or you are with at that particular time does not have a good level of consciousness, or he has impaired cognition, that he won't be able to recite how many attacks have been coming, when it did start, who saw what happened. So usually the family or the patient should be able to tell us these perceived changes. Perceived changes, what do you notice when my brother is going to have a seizure? Or does he pick things? Does he run about? Does he start chewing his lips, grimacing? Does he have nystagmus or abnormal eye movement? Does he shout? Does he see Z lines or black lines or loss of vision? Does he get difficult in breathing? Some people would smell of difficulty in breathing or feeling the air they're breathing is not enough. Others feel as if they're getting the heart pounding, palpitations. Others would complain of abnormal smells, smelling smoke, smelling onions, smelling blood in even areas where these smells are not there, or feeling abnormal movement on the skin or abnormal sensation. So you want to inquire, has he or she had any intercurrent infection? Has he had a pneumonia? Has he had a cough? Has he had a headache? Was he vomiting? Was he feeling dizzy? Are there other systemic illnesses? We want to know that about diabetes. We want to know about high blood pressure, like what our patient had. We want to know about if he had any chronic liver disease, chronic kidney disease. So these comorbid diseases, have they been happening? Does he drink and does he use any recreation drugs? Okay. So medication, we want to know about how good are you at taking your drugs? Are you good at taking them regularly? Are you taking at the same time? Is it poor adherence? Have we had a change in formula? Sometimes when you're changing, I'm switching you from carbamazepine to phenytoin. And then the patients get an attack within those 2 or 3 days when it's changing, or the week. Sometimes the brand matters. We know that carbamazepine, for like the commonest brand we have, is not the same as Tegretol. We know Dilantin is not the same as phenytoin. So there are different changes in the brand and different brands and different drugs. So during the planned withdrawal, sometimes we withdraw drugs. Maybe we are introducing some other drugs. Then we get these seizures, changes in medication, drug interactions with other prescribed drugs. As we know that some drugs might be eating other drugs faster, like having a plate of rice and you are 2 people on the plate, and whichever 1 spoon of rice you are putting, your friend is putting in 4 spoons. Well, so it means the person putting in 4 spoons of rice, he's an inducer. He induces, he eats faster than you. So at the end of it all, he has consumed 3/4 of a plate, and for you, you've eaten only a quarter. So sometimes you can give drugs, and one drug makes the liver eat faster than what it should, and this causes low concentration. So imagine giving a patient, let's say phenytoin 300 milligrams by mouth, you think it's 300 milligrams, but after blood circulation, and we note that you're giving him around 100 milligrams, okay? Then the new acute symptoms, for example, when you've had head injury, as we see in many patients. So having seen this from the history, then we go in to see the clinical assessment. And physical examination can just relieve additional information that can help us to raise suspicion of a true seizure and also maybe status epilepticus. Now, the most significant syndrome that we'll see is, sign is tongue biting. So for anybody who has a seizure and gets tongue biting, we are at least like 99% sure that it's a seizure than these other things which come on of fainting, being mute. Those are very non-specific, whereas tongue biting is very specific. So abnormal neurologic examination, which would be looking at the Glasgow Coma Scale, the level of orientation and all that. Then the skin, we could look at some mucocutaneous disorders, like in tuberous sclerosis, people have neurofibromatosis, those small swellings. Sometimes it's an earlier indication that they're going to have also this manifestation in the brain, and later on they'll have seizures. So we want to look at the age, definitely, age greater than 65 or even below, and then our causes usually vary. And then we have to look at the eye movements, really. Are they really deviated? Do they roll like this? What's the Glasgow scale? And then these help us to predict, as long as we see this abnormality, if somebody has a low Glasgow Coma scale, maybe scoring 3, he has abnormal movement or abnormal neurological examination, then it's very predictive that in case we send him he or her for imaging, the CT scan will be abnormal, able to pick up something, as we've seen in the case presented. Now, having gone through the normal what we see, so what could confuse us? What could be the differentials for us having seizures? Commonest is syncope. Syncope means having these fainting episodes, and including convulsive syncope, where we have brief seizure-like activity, and usually in the trunks, they could be tonic. Tonic means they get kind of like spastic, or they could occur in an uncomplicated way. It could be maybe like a transient ischemic attack, maybe mainly in the elderly patients. We have a very, very mild stroke like coming, and maybe there's blood obstruction in one of the vessels in the brain, and then somebody gets fainting episode. It could be a migraine, and we know migraine can cause very severe pain. They're on one side, they're causing tearing. That's a classic, but there could be other migraine with aura. Somebody gets bad smell, he feels tingling, palpitation, the same as a seizure. So there could be panic attacks and anxiety, where somebody is worried, I have a panel to see next week on Monday, or I have an exam, or I'm meeting some people, you're going to give a talk in public, and all this could cause like a seizure attack. Functional seizure, which psychogenic non-epileptic seizures. We've seen many kids, I'm sure many of us have seen, and whether in a big hospital, health center 4, health center 2, usually teenager girls, 16, 15, 17, they are mute, and they are stiff, they can't talk, they are breathing with a thumping of the chest. And the first time you are versed with such a person, you wonder if it's a seizure, they can't talk, the mom comes or the dad comes, the girl was picked from school, he can't talk, or he fainted, or they are beaten at school, or they're given or a corporal punishment or whatever. So initially, when I was still a young, inquisitive and very ambitious doctor, I would give diazepam. But then we noted, what's the difference between that psychogenic functional seizure and a real seizure? That when somebody is having a thumping, lifting your chest off the bed or the crotch, that's not a seizure, because a seizure cannot do that. or bring in that difficulty in breathing, pretending, or sometimes abnormal cries. So these are some of the things that you have to look at, and also look at the eyes, look at how the physical and functional characteristics of this presentation. Transient global amnesia, usually in people who are above 50 years. Narcolepsy with catalepsy, people who have sleep disorders or paroxysmal movement disorders, which can happen in any of these ages, especially the adults. So when do we decide to admit if you are advanced with this patient? So sometimes when you're in these facilities, either I'm in my private clinic, I'm in a low health center or district or very far, there are some things that should point. Somebody who has had a prolonged post-ictal state or incomplete recovery after a seizure, serious seizure-related injury, somebody has a faints or drops, and then he has a fracture. Status epilepticus, which we said continuous having seizing. Then any presence of neurological systemic illnesses that may require additional evaluation or anticipated difficulty to access or ability to complete the initial workup as an outpatient. Then you want to admit and really see how this patient is doing. So in the initial assessment, much has been said by the previous speakers, which I'll just to mention that common things occur commonly. We want to say, just highlight the ABCs, which we know, but here to highlight that glucose check is very common, very cheap, and readily available. Please check the glucose, because if you don't, we give unnecessary treatments, which are expensive, and also we request for unnecessary diagnostics, which won't help us. Okay, so that we have to check for the labs. Common things occur commonly. I want to start with malaria, which is very common at BS. Do a CBC, renal function. We want to look at if the urea is increased or creatinine is increased. In most labs that we have around the government hospitals, we request for 4 panels: sodium, potassium, and chloride. So we want to look at the sodium levels and we want to look at the potassium levels, which can be correctable. Then anti-epileptic drugs levels. This is at level 4 or tertiary levels. We want to know the levels of these drugs, and toxicology screen and arterial blood gases. Then we go on to do a lumbar puncture, depending on the cause. And we want to look at the cell count, which if it's a bacterial infection is going to be increased. We want to have look at the protein levels, which will tend to be increased in viral causes like encephalitis, even tuberculosis, and also in bacterial causes. Glucose, which tends to be low if there's an infection, lactate. Then other markers of inflammation, oligoclonal bands, gram stain, blood, bacterial culture, and cytology. And then additional CSF studies. Here we are mainly screening out for the new autoimmune epilepsies which are happening, and these are mainly caused by viruses, and we are targeting to look at things like varicella and herpes simplex viruses and other viruses. Not routinely done, but it's a new thing that even in modern countries where we are now screening a lot for viral epilepsy and autoimmune. So common things occur commonly, and here you want to look at the glucose level, serum, and in most cases, we tend to have seizures below 2.5 millimoles, because that's the threshold for the brain to know if our glucose is adequate or not. Sodium, less than 115 moles, but on like on the neurology ward, I've seen sodiums at 120, people having seizures. And until you correct the sodium, however much you give your sodium, valproate, phenytoin, carbamazepine, diazepam, these seizures won't go because you've not corrected the underlying pathology. Calcium, magnesium, and urea creatinine. So this is a table that was looking at the normal chemistry that we have to do in somebody who is having acute symptomatic seizures. So we further go on to do an electroencephalography, which is not mandatory then. It should not preclude the management of a patient with seizure, but it helps us to really to add to our diagnosis or to affirm. And it also helps in non-conclusive, non-convulsive status epilepticus to know if there is, it's really, if there are really seizures that we've not attended to, and also in helping us to monitor response to therapy. So imaging, CT scan is usually the most cheap and most readily available. It helps us to rule out any brain abnormalities, if there's hemorrhage, if there's a tumor, if there's a bleed or edema of any viral inflammation of the meninges. And but we have to know that it only identifies around 17% of the patient, which means the other 83 have to depend on your history and other investigations. And in patients living with HIV, when seizures happen, usually toxoplasmosis is a common finding, the most frequent finding. So we should keep that in the back of our minds. So currently, people in specialization, especially in neurology, prefer using MRI because it gives more definitive diagnosis regarding the cause of the seizures over the CT scan. But you have to know that in our setting, this is close to around $250 as compared to maybe $50 of doing a CT scan. So we have to. Yes, please.
Yes, we are quite short of time, maybe to be a bit fast. We have more 2 minutes.
All right, I have a few slides remaining. Thank you.
Okay.
Now, management, it takes, so 2 points to mention that the longer it takes to get your seizures under control, the harder is it to control them at all. So if you take 1 day to control the seizures or to start the patient on treatment, then it will be hard for us to control the patient. Then secondly, if we give first-line medication, we control around 80% of these patients if the drug is given within the first half an hour. So 2 points to note here that if somebody presents with a seizure and we don't give medication, they have a chance of getting a recurrence, say, within 2 years, at least close to 45%. So we should treat these patients aggressively. And then for patients who get recurrence, usually we will have an abnormal EEG and brain imaging, which is abnormal, and even patients who get seizures during the night. So initial management, one to correct that, give an injection of thiamine, which is 10 milligrams, and then give dextrose if the glucose is unknown, just in case somebody has hypoglycemia and we don't have a glucometer. Thiamine first, then glucose. Then these drugs have been already said: lorazepam, diazepam, midazolam. Midazolam is preferred because it can be used IM, can be used IV, and also intranasally and intrabuccal in patients where we can't access the IV lines. Okay, so if we're still having somebody having seizures, then we can go to phenytoin with a loading dose of 20. Other drugs are equally efficacious. Levetiracetam, which is Keppra, sodium valproate can be used. Not very common here, very expensive. and they are already recommended in 2019 by the ILE. Just to keep in mind that you have to monitor the blood pressure and the cardiac patterns by use of the EEG. So benzodiazepines all are there, which has been already said. I'll skip that. So phenytoin, this commonly used here. We have to monitor the heart, and it should be done in ICU or with people knowing that there is a patient on phenytoin. We don't mix phenytoin in dextrose because it will precipitate and hence it will cause us some bad effects. So if the phenytoin is not working, then we can move to phenobarbital. It also potentiates gamma aminobutyric acid, which is inhibitory neurotransmitter. And then we should avoid in patients who have liver disease and may cause Stevens-Johnson's disease, which is stage 3. So this management basically just gives us the general management, which has been discussed initial management, immediate measures. Then we'll give lorazepam. If not available, we can use diazepam. If no IV access, we can use buccal-midazolam. If no response by 10, then we can inform the intensive care unit. Then we give phenytoin, which you've all said. Then you can either use any of the 3 drugs, phenobarbital, sodium valproate, and levetiracetam. And if no response, we go to refractory seizures. And here we're going to admit in IC and use other drugs, propofol, ketamine, and midazolam. And then we really put the patient to sleep. And then after that, we'll try to move off one by one drug until that patient wakes up and we've controlled the seizures. So what are some of the challenges that make us not control the seizures? One, forgetting to do our ABCs, such that the patient is continually seizing and we've not protect their airway, and then we don't ventilate properly, so that we compromise other systems. When you don't monitor the heart and the breathing systems or monitoring, forgetting to do a glucose level, and we are not minding about the hypoglycemic changes. Having non-convulsive status epilepticus, where somebody is not jerking clinically, but is deteriorating in the neurological function. Then sometimes phenytoin may not be the appropriately treat that seizures which are coming secondary to drugs like alcoholic withdrawal, and here you are pumping with phenytoin, loading dose. And somebody has alcoholic withdrawal seizures or cocaine, and you're wondering why somebody is having this status epilepticus. So sometimes they are giving suboptimal doses of anti-epileptic drugs. I've seen some my interns sometimes are worried of giving high doses. Sometimes the seizure might be due to due to stressors, lack of sleep, or derangements, or vomiting, or even in other associated conditions like pregnancy. Okay. So, in conclusion, one as a take-home message, having a seizure patient with status epilepticus, we should work as a team, doctors, nurses, and pharmacists, to help us to reduce the mortality and morbidity of these patients. And this calls for a collaborative team of clinicians, specialists to work together so that we achieve the best standard of care. Lastly, let's communicate to our patients and the family, really emphasizing the diagnosis, the treatment options, and the possible outcomes, rather than working alone and then we get bad results and then we are able to communicate. Thank you for listening. Questions are welcome. Thank you.
Thank you so much, Dr. Kadu, for that discussion. I'm sure that we've learned quite a number of nuggets from your discussion. And even from the other experts. So right about now, we're going to share the post-test, sorry, to be on your screens. You can answer it as our dear experts answer a few questions. We have some questions for Dr. Kadu, maybe. You can, only two questions. You can raise your hand and we'll give you a chance. Okay, if we don't have any questions, we're going to have parting shots from a team of experts. And we are beginning with Dr. David. Just, you have 10 seconds.
Yes, thank you, colleagues. We should remember that managing a patient with convulsions it's quite hectic and it requires teamwork always. It should be a multidisciplinary team to manage this patient. And most importantly, never forget to do a blood glucose for these patients. Thank you.
Thank you so much, Mr. Ntanda.
Thank you very much. We all agree that the success of our patient transport is plan, communicate. Plan, communicate. The rest will have the best of the patient. Thank you for that.
Thank you. Then, Sister Helen.
Thank you, our dear audience. My message to the primary caregiver, the nurses, when you come across a person who is convulsing, timely recognize this person needs emergency care and always use the ABCDE approach, which will make you look through the critical areas that prevents neurological damage for such a patient. And this is a multidisciplinary approach. Don't die alone, call for help so that we can intervene and save lives. Thank you.
Thank you so much. Dr. Kadu is online. Please, your parting shots.
Oh, sorry. Am I expecting a question or? I don't know.
Unfortunately, people have not asked. So we are kindly requesting for your parting shot.
Yeah, so epilepsy is seizures, very common. That's one of the commonest things that we see day to day. And definitely we still have stigma in us, the doctors and nurses. And it's us to stand at the front to combat this and help these patients live a normal life. And we believe with us as the doctors and nurses and people who have patients affected or relatives, it's us to be at the front to help up this and make their lives better. Thank you.
Thank you so much. I will also request Dr. Ronald Kasigezi, who's been online and in our chat answering questions, also to give us some parting shots. You're welcome, Dr. Ronald. Okay. He's in? Yeah. Okay. Dr. Ronald.
Thank you very much. The audience and every presenter, you've done a wonderful job. Seizures are quite common and it's important for us to recognize them and manage them appropriately. I think by now you know some experts you can consult. I wish everyone a lovely day.
Thank you so much. So we're going to request each one of us to unmute our cameras. Okay. Someone that as we put our cameras on, we are waiting to see you from wherever you are.
Hello.
Yes.
Excuse me, please.
Yes, that's Kathy. Yes.
Thank you very much for this session. I actually posted a question earlier during Dr. Kadu's presentation, which was very enlightening. He spoke about non-convulsive seizures, and I asked that they're dealt with in the same way as convulsive seizures, and then also, can we talk about status epilepticus for non-convulsive seizures? Thank you very much. I hope I was clear.
Okay, that question goes to Dr. Kadu.
Yes, I heard the last bits of the question are not very clear. However, for status epilepticus means we have recurrent seizures, so we can have non-convulsive or still convulsive status epilepticus. So as long as the brain is still having seizure activity, both can happen in the physical form that we see and the non-physical form. So we can have still non-convulsive. So in case we move from status epilepticus, we can go to refractory seizures, which are having status epilepticus, which is not really getting to a seizure freedom, what we will term as refractory seizures.
Thank you so much. I want to thank you all for attending and being a great audience. And thank you for, I know you're blessed with knowledge, and our team of experts, we are really humbled to tap in your rich knowledge. And thank you so much. May the good Lord bless you.
Shout out to people, you know that.
Okay, maybe to say hello to Ojambo Ocheng, Rachel Abba. I can see Magoka Sharifa, Oyela Hillary Peace. My shout out to you.
For the blood as well.
Okay. God bless you.
All right, thanks everyone. See you next. Bye.